Hello. Post-op pulmonary complication is one of the common and major cause of perioperative morbidity and mortality. In this section, we would discuss all the strategies that we can employ in perioperative period to minimize this post-op pulmonary complication. So what are the preoperative strategies, the intraoperative strategies, and the postoperative strategies we will discuss. And we will also discuss that what are the evidence-based medicine which suggests on these strategy. So what are the major let's say post-op pulmonary complications that patient can have and which would increase the patient's hospital stay and can cause the ICU admission in our patient. So let us first discuss the major categories of clinically significant pulmonary complication which the patient can face in post-op period. The first is atelectasis, one of the commonest post-op pulmonary complication which we see in our patient. So atelectasis. Then your pneumonia. So number of patients in post-op period who are predisposed to some pre-op infection or some let's say infection can develop pneumonia. Then ARDS, that is adult acute respiratory distress syndrome. Then aspiration. Then your exacerbation of the patient's pre-existing pulmonary diseases like COPD and asthma. So exacerbation of underlying lung disease, underlying chronic lung disease, right? And one very, let's say, not rare, quite common post-op complication which can develop in patients is your bronchoconstriction, bronchospasm. So we need to delineate the risk of bronchospasm developing in our patient also, the patients who are at a high risk and how to mitigate that the risk and how to prevent this complication from happening, because all these complications can cause the increased hospital stay and ICU admission. So bronchoconstriction. So these are the major clinically significant pulmonary complication which can develop in our post-op patient. So we need to discuss that the strategies which I am going to discuss with you, do we employ those strategies to prevent the perioperative pulmonary complication in all patients? Well, do we need to use the strategies in all patients? Actually, no. We need to use these strategies in patients who are at a high risk of developing pulmonary complication. The patient who have one or two risk factors and are posted for the surgeries which can be associated with pulmonary complications like upper abdominal surgery or thoracic surgery or head and neck surgery, or in patient who are not for these kind of surgeries but have 3 or 4 risk factors of post-op pulmonary complication developing in them. So it is not to be practiced in every patient. Generally it is reserved for patients those are at higher than average risk. So what are the patients who are at higher than average risk? So patients who are posted for upper abdominal surgery, patient who are posted for thoracic surgery or head and neck surgery. Now these surgeries increase the risk of post-op pulmonary complication, and if patient has 1 or 2 risk factors, now they become a high chances of developing, post-op pulmonary complication, 1 or 2 risk factors. So in them we need to practice these strategies, or we need to practice the strategies in patient who are posted for low risk surgery but have 3-4 major risk factors. So patients with 3 or 4 risk factors of developing the pulmonary complications. So what are the risk factors? We need to know the risk factors also, right? So definite risk factors for developing post-op pulmonary complication. Your patient posted, as I already said, posted for upper abdominal, thoracic, head and neck, neurosurgical and abdominal aortic aneurysm surgery. Then patient posted for emergency surgery, because in emergency surgery we don't have enough time to let's say optimize the patient. So if patient are posted for emergency surgeries, lot of lung condition can be also unoptimized and they are at a high risk of developing post-op pulmonary complications. So we need to deploy whatever strategies which we can put to prevent this. Then old age above 65, these patients have a low lung reserve. They have a lot of comorbidities of lung associated in them, and they have also basal atelectasis very common, and they are very predisposed to the let's say side effects of our anesthetic agents as well. Then surgery lasting greater than 3 hours. More the duration of surgery, more is the risk of developing basal atelectasis and more of the risk of developing the pulmonary complication. Poor general health status of the patient defined by ASA grade more than equal to 2. So, the risk of pulmonary complication is more in patient ASA grade 3 and 4. Then patient with heart failure, they are at a higher risk of developing lung complications. Low serum albumin level less than 3 gram per deciliter. Patient having history of COPD. Patient who are cigarette smoker and an active smoker who has smoked cigarette in 8 weeks prior to being posted for surgery. Intraoperative long-acting neuromuscular blockade used in the patient. So, general anesthesia being given, and in general anesthesia, paralysis is being practiced with long-acting neuromuscular blockade. Then functional dependency of the patient. Patient is not functionally independent. Again, it is pointing towards a low ASA grade. A high ASA grade, I must say. Of patient associated with obstructive sleep apnea, and patient having a history of recent lower respiratory tract infection, and have frailty present in the patient, high frailty index, the old age patient again, I would say. Age is just a number. You cannot quantify the complications just with age. So a patient who is having who comes under old age but has a good functional independence, has low frailty, they are at a less risk. And patient who are relatively younger but have a high frailty, high dependency, they are at a higher risk. So every patient is different. So these are the definite risk factors. Now there are some probable risk factors as well. So general anesthesia compared to the regional and the blocks are associated with most post-op pulmonary complications. So general anesthesia. Then if patient's baseline PaO2 is more than 45, so they are at a higher risk of developing lung complications. Patient having anemia, hyperglycemia, an abnormal chest radiograph. May not be a recent abnormality, but any abnormality in chest radiograph. And current upper respiratory tract infection and post-operative nasogastric tube placement. If they require post-op nasogastric tube placement, that is patient posted for abdominal surgery in which gut handling has been done, and definitely they will be way beyond nasogastric tube. So nasogastric tube in post-op period increases the risk of the perioperative pulmonary complication. So these are the probable risk factors. So if some patient has more than 3-4 of these risk factors, the definitive and the probable risk factors, we need to employ all the strategies to prevent the perioperative pulmonary complication. Or if patient is posted for these high risk surgery and have one or two also the risk factors, we should use all the strategies to mitigate the post-op pulmonary complications. So let us talk about the preoperative strategies. Strategies has been divided into pre-op, intra-op and post-op. So let us first talk about preoperative strategies. So one of the risk factor for post-op pulmonary complication is smoking, a history, active smoker, or a patient who has smoked within 8 weeks being posted for the surgery. So smoking cessation is one of the important pre-op strategies which we can employ for minimizing the post-op pulmonary complication. See, the perioperative period is one of the best period to motivate the patient for a cessation of smoking, right? Now they can be told about all the ill effects of smoking, and they can be told about the complications which is associated with smoking, the long-term, the short-term complications, and the smoking cessation can be tried in these patients. So just remember that current cigarette smokers have a very high risk for post-op pulmonary complication. Now smoking cessation offers multiple benefit. Smoking cessation offers multiple benefit. Now, not only the direct benefit for lung, it also reduces the post-op wound infection and improves overall overall recovery in the patient. So it improves outcomes like wound healing and post-op pulmonary recovery and post-op pulmonary recovery, right? Now, the duration for smoking cessation, which would offer us all these benefits, is a bit controversial. It is written differently in various studies. But what has been suggested in most of the, let's say, trials and study, that smoking cessation for more than 4 to 8 weeks would definitely give a benefit in reducing the post-op complications in the patient. So, duration of abstinence to reduce complication is not well established. So it is not clear cut, not well established. So what is suggested? That 4 to 8 weeks is what is preferred. Now this is also a bit controversial. Now one important clinical question recently came, that if someone is stopping the smoking for less than 8 weeks prior to surgery, in some patient there has been noticed that increased risk of pulmonary complication, right? If it's the abstinence is for less than 8 weeks. So this clinical question came out as a result of one trial which was done, a prospective study on 200 patients undergoing CABG surgery, in which patient was asked to stop smoking for 2 months or less, had a pulmonary complication rate almost 4 times that of patient who had stopped for more than 2 months. So for more than 8 weeks if they have stopped, right, compared to the patient who had stopped the smoking for less than 8 weeks, the rate of complication was more in the patient who had stopped for a lesser time period. So rate of complication was almost 4 times that of patient who had stopped for less than 2 months. So the question arose that is the smoking cessation for a lesser duration, less than 8 weeks, offering a real benefit, or it is increasing the risk of complication. So a lot of trials were done subsequently. So subsequent systemic review and meta-analysis has not supported the concern about short-term smoking cessation being associated with worst outcome. So some of the recent trial has not supported this study. Now 3 meta-analysis address the question of optimal duration of smoking cessation, 3 very well conducted studies. In one systematic review, there was no difference in total post-operative or pulmonary complication between current smoker and recent quitters, that is for less than 8 weeks, while they identified no increase in risk for the recent quitters as well. Now the trial which presented with this question, that recent quitting of smoking is increasing the risk of complication. Now this was negated by this trial. It did not show any benefit of recent quitting, but it did not even show any increase in the risk of complication. Then there was a separate analysis of a large number of trials, that is 6 RCT and 15 observational study was studied, and they found the reduction in both the relative risk and of overall complication and the pulmonary complication for past smokers as compared with current smokers of any duration. So abstinence of smoking of any duration was giving the benefit of less complication being associated in the patient. So there was no difference between early and late quitters, and each week of cessation increased the beneficial effect of overall outcome in the patient. So if a patient comes to you who is a smoker, and whenever he is posted for surgery, it would be always good to advise him to quit smoking before surgery, right? Active smoking prior to surgery definitely increases the risk of post-op pulmonary complication and also increases other risk in the patient, right? So without fearing that there would be a risk of increased complication, we should advise our patient to quit smoking prior to surgery. This is one of the pre-op strategies. Now let's talk about the other. If a patient has a history of COPD, patient with a history of COPD. Now, if they are stable patient, I mean the COPD is stable, patient is on medical therapy and has history of any recent hospitalization, is stable, then the risk is very minimal. But unstable COPD with an exacerbation, that is a contraindication for taking the patient for elective surgery. So this is COPD is important patient related risk factor for post-op pulmonary complication. Post-op pulmonary complication. So as I said that if patient is in exacerbated state, then we should wait for the patient to come on the baseline state and then take for elective surgery. So patient should be medically managed and should be optimized to the baseline stage. So best possible baseline level should be achieved, right, before elective surgery. Now, if patient is showing any acute exacerbation, the elective surgery should be delayed. If a patient is on steroid, now perioperative steroid stress dose of steroid should be considered depending upon the type of surgery the patient is posted for. So if a patient is on steroid, now perioperative stress dose of steroid should be considered. So, and if you don't want to give the steroid, then get a hypothalamic pituitary axis, get evaluated whether it is under the steroid suppression or not. So we have to consider this as well. Now, if a patient has a history of asthma, then the level of control of asthma should be evaluated. So level of asthma control should be evaluated, evaluated. Now, if patient is not well controlled, then the current medical therapy should be escalated, and once the well control is achieved in the patient, the control of asthma is achieved in the patient, then only patient should be posted for elective surgery, especially if the surgery requires general anesthesia with airway manipulation. So if patient is not well controlled, then medical therapy should be increased. The medical therapy should be increased. So escalated. So medical therapy is escalated, right, to have a good control. Now, elective surgery should be postponed if patient has a wheeze, or if patient has let's say less than 80% of the predictive value of the peak expiratory flow. So if it is an uncontrolled asthma, the elective surgery should be deferred. So elective surgery should only be undertaken in patient with history of asthma if they are free from wheezing and peak expiratory flow is more than equal to 80% of predicted, right, if there is a good control in them. And before taking the patient for surgery, before induction, the inhaled short acting beta agonist should be 2 to 4 puffs should be given. That should be a standard practice. So inhaled short acting beta agonist, 2 to 4 puff 30 minutes before induction, and a proper history should be taken that is there any drug or any condition which exacerbate the asthma of the patient, like aspirin induced asthma exacerbation can be present in the patient. So if such kind of history is there, that drug should be avoided in the patient. right? Okay. Now, if a patient is on antibiotic, let's say recent infection has been suspected in the patient, and patient is on, or diagnosed in the patient, and patient is on antibiotic, the change in the sputum thickness or sputum color, and patient is on antibiotic, then first the baseline level should be attained with the full medical therapy, and then the patient should be taken for surgery. So pre-op antibiotics, preoperative antibiotics is antibiotic is only indicated in lower respiratory tract infection. That is, the sputum of the patient, the color, the thickness, etc. has changed. And elective surgery should be cancelled until the patient achieve the baseline level, until patient returns to the baseline. So I'm writing repeatedly baseline. That may not be entirely normal, but what is the patient's baseline is what we have to target. Okay. Now, upper respiratory tract infection. Now, if you have noticed, in the risk factor for post-op pulmonary complication, the upper respiratory tract infection is a probable risk factor. It's not a proven risk factor. Lower respiratory tract infection is a definitive risk factor. So actually the studies supporting the upper respiratory tract infection as the probable cause of increasing the post-op pulmonary complication in the patient is less, especially in adult. It is very less. Most of the studies has been done in children, right? But what is advisable, that if patient has an active upper respiratory tract infection or a recent upper respiratory tract infection, then we should wait for the patient to return to the baseline, and the elective surgery should be postponed. So risk of anesthesia and surgery in patient with upper respiratory tract infection is unclear, but it is reasonable to delay if there is an active infection. It is reasonable to delay elective surgery in active infection. So if patient is having active sneeze or active, let's say patient is having fever signifying the viral infection, right, then definitely the manipulation of the airway can cause complication. So we should defer the elective surgery, or we should take all the precautions if we are taking the patient to prevent any complication to happen. Okay. Now, lower respiratory tract infection. Lower respiratory tract infection is a definite risk factor. So when a patient has a lower respiratory tract infection, the immune response of the lung following this infection causes inflammation, endothelial changes in the lung, and altered microvascular permeability. All this could increase the risk of infection. So in lower respiratory tract infection, the immune response in lung following infection includes inflammation, endothelial damage, altered microvascular permeability. Now, all this will increase the risk of post-op pulmonary complication. So, all this increases risk of post-op pulmonary complication. So, elective surgery should be avoided in the patient with the symptoms, and 2 to 4 weeks, let's say if patient has active pneumonia, 2 to 4 weeks after the when the patient achieves the baseline, then only the patient should be taken for the surgery. So elective surgery should be avoided in patient who has symptoms, in patient with symptoms. and up till 2 to 4 weeks. 2 to 4 weeks of lower respiratory tract infection, that is pneumonia, lower respiratory tract infection. So this is a definite risk because it causes a lot of changes in the lung and which increases the risk of post-op pulmonary complication when patient is being given anesthesia and other complications contributing comes in the patient, right? Okay, now there's one very good study which I want to quote. The perioperative risk is likely to be elevated for several weeks after severe lower respiratory tract infection requiring hospitalization or mechanical ventilation. So the risk is more for several weeks. So that's why the gap of 2 to 4 weeks has been suggested. Now, in a prospective multi-center study that was responsible for deriving, the people who derived the ARISCAT index, right? The respiratory infection, they defined respiratory infection as patient receiving antibiotics for suspected respiratory infection and having one of the following: new or changed sputum, new or changed lung opacity, fever, leukocyte count more than 12,000 within a month before surgery, were strongly associated with post-op pulmonary complication. So lower respiratory tract infection patient was strongly associated with post-op pulmonary complication if it was within the month before surgery, and that's why 2 to 4 weeks a gap would bring the patient lungs to the baseline level, and that gap is required if possible for elective surgery. So the decision to proceed with elective surgery in this setting of a recent lower respiratory tract infection depends upon, it should be individualized considering the emergency or urgency of the surgery, the risk of complication and risk of delaying the surgery. The risk of complication coming in the patient and risk of delaying the surgery, that is the urgency or emergency of the surgery and the risk of complication which may develop if we take the patient for surgery. So we should find a balance, right? And the decision should be individualized. Okay, if patient has a recent COVID infection, what does that suggest? Now, previously, when a patient had any kind of COVID infection, that is a mild, moderate or severe COVID infection, what was the advice that for 7 weeks after infection, till 7 weeks after infection, the risk of pulmonary complication is higher in the patient, right? Overall complication is higher in the patient. But with recent vaccination and proper management of the COVID, in a low risk patient, the risk associated has marginally reduced. So there is no increased risk in a patient with a mild COVID infection. But patient with moderate to severe COVID infection, the risk is there up to 12 weeks after let's say COVID infection. So early evidence suggests a drastically increased risk of pulmonary complication, and mortality in surgical patient after the coronavirus infection. Pulmonary complication and mortality in surgical patient posted after COVID infection. Patient posted with COVID infection of any severity, and this high risk is maintained till 7 weeks after infection. So previously the guideline was something else, but now newer studies have found, the new data suggest no increase in risk with mild infection. So no increase in risk with mild infection, right? And if it is moderate to severe disease, then for 12 weeks the risk is increased. So there was a memorandum passed by ASA. So in 2023, American Society of Anesthesiologists and Anesthesia Patient Safety Foundation updated the practice statement advices on avoidance of elective surgery within 2 weeks and individualize the approach, balancing the risk and benefit to the surgery between 2 to 7 weeks after COVID infection. So what did I say? Previously, for any COVID infection, the patient was not taken for surgery for at least 2 weeks. But the recent guideline has changed and they advise avoidance of elective surgery within 2 weeks, which was earlier practice. They have changed it to the individualized approach, balancing the risk and benefits to the surgery between 2 to 7 weeks after COVID infection. And as I said, mild infection, no increased risk, so patient is taken for the surgery. And moderate to severe infection, there is a increased risk up to 12 weeks. So 2 to 7 weeks, right? For 2 to 7 weeks, the risk benefit ratio has to be properly optimized, properly taken care of, it should be properly calculated. Decision should include consideration of the severity of the COVID symptom at the time of infection, ongoing symptom, comorbidities, and complexity of the surgery. All this should be included in making the decision. Okay. Now, one of the very important pre-op strategies to minimize the post-op pulmonary complication is proper pre-op oral care. Now, proper pre-op oral care, especially for cardiac surgery, major surgeries like cardiac surgeries, has shown to give a very good benefit in the patient of reducing the post-op pulmonary complication, right? So, for cardiac patient, it is normally advised, the cardiac surgery, it is normally advised to go for twice chlorhexidine mouthwash, let's say 1 week prior to surgery. Now, this is should be practiced this in every patient. The chlorhexidine mouthwash is not necessary, but proper oral hygiene should be practiced in every surgical patient posted for surgery. So, pre-op oral care should be optimized. So, good pre-op oral care, good pre-op oral care, good pre-operative oral care decreases the risk of post-op pulmonary infection, postoperative pulmonary infection. Why? By decreasing the oral bacteria, right? By decreasing the oral bacteria. So, all surgical patient should practice a good oral hygiene, good oral hygiene. Not necessarily that every patient should have a good mouthwash with chlorhexidine, etc., but they should practice a good oral hygiene. Okay. Pulmonary rehabilitation, again, a very major role of pulmonary rehabilitation. You know, post-op, if patient practice the strategies to minimize the atelectasis, to expand the lung, etc., that would reduce the post-op pulmonary complication. Now, the teaching of these strategies to expand lung should start in pre-op period only. So, the pulmonary rehabilitation includes aerobic exercise, breathing exercise, and inspiratory muscle training. Breathing exercise and inspiratory muscle training. And patients should be trained for all lung expansion maneuver like coughing, like spirometry, like your let's say breath holding. So patient should be educated for lung expansion maneuver. So what are the lung expansion maneuver? Coughing, incentive spirometry, and deep breathing. All these maneuver would expand the lung. Okay. So summary of all pre-op strategies. Smoking cessation preferable anytime patient posted for surgery. So smoking cessation preferably for more than 8 weeks, but anytime. Any briefer period of cessation also is not harmful and still provide the non-respiratory benefits. Patient with COPD or asthma, optimize the control with inhaled bronchodilators and possibly inhaled steroids. Patient with flare of COPD or asthma, systemic glucosteroid should be used for management and delay the elective surgery until a good control and the patient has returned to the baseline. Reserve preoperative antibiotic for patient with sign and symptoms of lower respiratory tract infection. It should not be used in all the patient with upper respiratory tract infection. The pre-op antibiotic should not be started. Delay the elective surgery for at least 2 weeks for patient with COVID virus, influenza virus or lower respiratory tract infection. For patient with more severe diseases, delay up to 7 weeks whenever appropriate, if it's appropriate. So at least for 2 weeks post infection, and in case of severe disease, at least for 7 weeks. Counsel the patient for preoperative oral care. Provide preoperative education regarding lung expansion maneuver. So patients should be taught for all the lung expansion maneuver, which they will practice in post-op period as well, and pre-op period would be the best time to teach it. And patient with increased risk of pulmonary complication, initiate chest physiotherapy like aerobic exercise, breathing exercise, inspiratory muscle training up to 2 weeks before surgery for the optimum benefit. Up to 2 weeks before surgery for the optimum benefit. So these are all the pre-op strategies that we have to practice. Now, what about the intra-op strategies? What about the intra-op strategies? Now, intra-op strategies, the first would be selecting the type of anesthesia, selecting the type of surgery in high-risk patient, right? So, let us talk about first, and then obviously the lung ventilation which we are doing the patient in intra-op period. Everything should be properly planned in high-risk patient. So, selecting the type of anesthesia. If the patient is at a high risk of developing post-op pulmonary complication, and if the surgery is possible with regional or neuraxial blockade, it should be preferred over general anesthesia because risk of post-op pulmonary complication is higher with general anesthesia. We have already discussed that general anesthesia is one of the probable risk factor for developing post-op pulmonary complication. So, selection of the type of anesthesia. Selection of type of anesthesia. Now, general anesthesia is at higher risk compared to spinal and epidural anesthesia and nerve blocks. So, wherever possible in high-risk patient, we should go for these techniques. So, in asthmatic patient, my asthmatic patient or COPD patient, I preferably go for the regional or neuraxial technique if the surgery is possible with that. But if I have to give general anesthesia only for the surgery can only be done under GA. There are so many surgeries which only requires GA. Then the drug should be properly chosen. I would choose all the bronchodilators and use intermediate acting neuromuscular blocking agent because long acting neuromuscular blocking agent has been associated with a risk of residual neuromuscular blockade in post-op period and increased risk of post-op pulmonary complication. So, for GA, we will use the anesthetic agents which are bronchodilator, So, if I revise what drugs are bronchodilator, then obviously you all will answer your propofol, your ketamine, ketamine plus dexmedetomidine combination. So, I would go for propofol. I would choose the agent like propofol. I would choose the agent like ketodex, and I will choose sevoflurane over other inhalational anesthetic agents, right? So, these agents we will use, and we will use intermediate acting neuromuscular blocking agent. Intermediate acting neuromuscular blocking agents. So, avoid long acting because of the risk of post-op residual neuromuscular blockade with long acting is very high. Nowadays, hardly we use pancuronium or DT curare, which are the long acting one. We are using intermediate acting one, vecuronium, rocuronium, and this is the part of Intraop strategies to minimize the post-op pulmonary complication. Okay, now duration of surgery. In a patient with a very high risk of developing post-op respiratory complication, we should choose the procedures which could be done faster so that the duration of surgery and duration of anesthesia should be minimized. So, duration of surgery should be tried to be kept less than 3 to 4 hours, because more than 3 to 4 hours have higher risk of pulmonary complication, pulmonary complication. Then number of surgeries can be done by different technique like open laparotomy or laparoscopy or robotic technique. So definitely for less invasive technique should be practiced in these patients, that would infer a much more benefit in preventing post-op pulmonary complication. So there are some high-risk surgery. Patient posted for high-risk surgery. High-risk surgery should be cared in more intensive way. Multiple strategies should be employed in them. So what are the high-risk surgery? Already we have discussed the upper abdominal surgery, then open aortic surgery, open aortic aneurysm surgery, then your thoracic surgery, your head and neck surgery. All these surgeries are at a higher risk of developing post-op pulmonary complication. Okay, now ventilation. If I give GA, and how do I maintain the ventilation of the patient? That holds a very good role in preventing post-op pulmonary complication. So we should practice, if we are giving general anesthesia and we are practicing ventilation, lung protective ventilation. So what is lung protective ventilation that we need to practice? Low tidal volume, higher level of PEEPs, and alveolar recruitment maneuver. So low in high risk patient, this is not to be done in every patient. So low tidal volume, that is 6 to 8 ml per kg predicted body weight. Always the ventilation is calculated by predicted body weight. Then higher levels of PEEP, that is 6 to 8 centimeter of water to be minimum, 6 to 8 centimeter of water, and alveolar recruitment maneuver in our high risk patient. Alveolar recruitment maneuver should be practiced. So we should go for lung protective ventilation. Now there was a very important study which was conducted, a very popular study, Prime Air study. So there was a study called Prime Air study. Now this Prime Air randomized trial. Now this used bundle care for preventing the post-op pulmonary complication. So what was the part of the bundle care? Bundle care practice which was used in this Prime Air randomized control trial. The first was they in the test group, the intraoperative lung protective ventilation they instilled. Then they paid a lot of attention to the neuromuscular blockade reversal. I mean, very judiciously they followed the neuromuscular blockade level by neuromuscular monitoring and using the direct reversal agents. Then pre-op patient education for let's say lung expansion maneuver. Then incentive spirometry was very judiciously done in all the patient, and early mobilization was practiced. So in bundle care, the intraoperative lung protective ventilation, intraoperative lung protective ventilation. Then the second thing of the bundle was the heightened attention to neuromuscular blockade reversal. Then pre-op patient education for lung expansion. Pre-op patient education for lung expansion maneuver. Then incentive spirometry, and your early mobilization. So these 5 strategies was applied in the bundle care in the test group. Now, when they employed these 5 strategies, what they found in the study, that overall outcome of decreased post-op pulmonary complication was not different from the standard care which was done in the patient. So kind of this bundle care was challenged by this prime air randomized trial, and it was suggested that the bundle care should not be practiced in all patients. It should be practiced only in patient with a high risk, because overall, compared to the standard care, it was not giving us much of benefit. Okay, then summary of intraop strategies. So what are the intraop strategies? Choose a shorter period of surgery if possible, less than 3-4 hours. Choose less invasive procedures like laparoscopy or robotic to avoid the longer duration. Choose neuraxial rather than general anesthesia. Utilize regional anesthesia when it is an option. So if I can give a combination of regional anesthesia with general anesthesia, it should always be employed, because it will give us a better pain control, decrease the requirement of the drugs we use in GA. So overall benefit would be good. Then patient with COPD or asthma, administer inhaled short-acting beta agonist 2 to 4 puffs 30 minutes prior to induction. So this should be very much practiced. And when invasive ventilation is being given to the patient, then low tidal volume, the higher PEEP and alveolar recruitment maneuver should be practiced. Avoid long-acting neuromuscular blockade for producing paralysis during the procedure, and assure full reversal of neuromuscular blocking agent. Use the reversal agents like Sugama-Dex whenever it is possible, and quantitative monitoring rather than qualitative monitoring if it is available. So these are the intraoperative strategies to prevent post-op pulmonary complication. Now let us talk about postoperative strategies. Now post-op patient, the first postoperative strategy is use of non-invasive ventilatory support. A lot of post-op patients, they may have some respiratory distress in them, and if we not timely intervene, then there may be a possibility of reintubation happening in them. But timely intervention by non-invasive ventilatory support will reduce the risk of reintubation in them, and would also improve their overall outcome. So the timely intervention with non-invasive ventilatory support in patient with respiratory insufficiency. So what do I mean? What is our post-op patient with respiratory insufficiency? If the patient is tachypneic, if the respiratory rate is high, if it is shallow breathing, or if it is labored breathing, or if the patient saturation is decreased, patient is in hypoxemia, in this case, we should go for timely non-invasive support, like we can go for CPAP, we can go for PSV, right, through non-invasive, right? But routine use of these modalities in every patient, right, who are not showing these respiratory insufficiency is not advisable. So non-invasive ventilatory support in the required patient, right? There are some studies which has promoted in cardiac patient, a trial involving 216 cardiac surgery patients found pre and post-operative non-invasive ventilation using BiPAP was associated with reduced risk of the 30 days cardiopulmonary failure. So it has shown benefits in high risk patient, but it is not to be practiced in every patient. Now lung expansion maneuver. Now there are many lung expansion maneuver, and the teaching of the maneuver starts from the pre-op period only. Now what are the lung expansion maneuver? The chest physiotherapy, right? The role of chest physiotherapy is not well established. Then deep breathing exercises and your incentive spirometry, and these are like in which we need the patient's cooperation, and the patient in which we don't need the patient cooperation, the lung expansion therapies, we can put the patient on CPAP or BiPAP, right? These are not patient dependent lung expansion therapies. So in patient with a high risk, we can use the required lung expansion therapy. So lung expansion therapy like chest physical therapy, your deep breathing exercises, right? Your incentive spirometry, incentive spirometry, right? All this should be used. Now remember, deep breathing exercise and incentive spirometry is most effective if we start teaching it from pre-op period. So it is more effective if we start using it from pre-op period, pre-op period, right? And 2 weeks prior to patient getting posted for surgery would give us the optimum benefit. Now the other techniques like your IPPV or CPAP, this can be used in selected patient, not in all patient, selected patient for lung expansion. Now let's talk about the deep breathing exercises. How do this deep breathing exercises are done? Now deep breathing exercises, patient is asked to take slow deep inspiration, hold the breath for 3 to 4 seconds and then slowly expire to functional residual volume, slowly expire to functional residual capacity. Okay, so patient is asked to take slow deep inspiration, hold it for 3 to 5 seconds and then slow expiration to functional residual capacity. Now how many we have to do? 30 deep breathing deep breaths every hour, right? Every hour at the time when the patient is awake prior to surgery would give us the maximum benefit. So the deep breathing exercises is done slow deep inspiration, hold for 2 to 5 seconds and then slow exhalation, right? 30 deep breaths hourly whenever the patient is awake in pre-op period. Okay, the incentive spirometry, we just give the spirometer and it's a patient can visualize what progress the patient is making. So this can also be practiced. Okay, now the other strategies are early mobilization. The early mobilization has reduced the risk of pulmonary infection substantially. Most of the studies have proven that. So as soon as possible after the surgery, the mobilization should be encouraged in the patient. So early mobilization decreases the risk of pulmonary complication. It helps in better pulmonary complication. It helps in better clearance of the lung and it helps in better pulmonary toileting as well. So early mobilization should be practiced in all surgical patients, okay. Then IV mucolytics, giving bromhexine etc. IV mucolytics had not shown to have a proven benefit. So may be used, may not be used. It is not something which has a proven benefit in our evidence-based trials. So IV mucolytic like bromhexine has not shown proven benefit, right? It has not shown any proven benefit of decreasing post-op complication, pulmonary complication, right? Okay. So IV mucolytic does not have much role. Then adequate pain control should be very importantly practiced. Multimodal post-op pain control, multimodal analgesia should be practiced because this will lead to early mobilization of the patient. It will lead to proper coughing out and lung expansion of the patient. So adequate pain control through multimodal analgesia should be practiced. Now the one thing we need to take care in that when we are employing multiple pain control strategies, then remember to minimize the opioid as much as possible. So in all the patients in whom the NSAIDs can be given, NSAIDs plus paracetamol combination, acetaminophen combination, along with the peripheral nerve blocks, if it is feasible for the surgery, should always be practiced in all patients, right? And supplemented with non-opioid analgesic. Now, opioid should only be reserved as a rescue analgesic therapy, because opioid can cause the respiratory depression in post-op period and can increase the risk of post-op pulmonary complication. So, the strategy should be as much possible as possible non-opioid. Now, goal-directed fluid therapy. Now, overzealous intra fluid and post-op fluid can again cause a problem. So, goal-directed fluid therapy, optimum fluid therapy, optimum fluid to maintain normovolemia, right? And patients should be encouraged, oral feeding should be reestablished ASAP, as soon as possible, according to the type of surgery. Okay. Avoid nasogastric tube. Now, if the post-op patient requires a nasogastric tube for gastric desufflation, then only the nasogastric tube should be put. Otherwise, the nasogastric tube should not be put in our post-op patient, because it increases the risk of pulmonary complication. So, nasogastric tube in situ increases risk of pulmonary complication, right? Increases risk of pulmonary complication. So, should be avoided if possible. Now, it should only be there when it is required. Unnecessary nasogastric tube should not be introduced. Okay, then so we talked about all the strategies. There are two landmark trials which I want to talk about. One already I have discussed, but again I will talk about. That is your prime air randomized trial, which used bundle strategies for preventing post-op pulmonary complication. In this, the strategies was the aggressive incentive spirometry, that is 50 breath daily than usual care on post-operative day 1 and 2 of incentive spirometry. The aggressive incentive spirometry, the word is aggressive. Intraoperative interventions like increased PEEP, low driving pressure, increased neuromuscular blockade reversal, pre-op patient education, and more early ambulation in moderate or high risk patient requiring abdominal surgery, early ambulation compared to the routine practice. Despite these interventions, there was no significant difference in average post-op pulmonary complication severity, and an increase in the rate of severe post-op pulmonary complication was seen in the intervention group, right? So, high use of intra and post-operative preventive strategies in the usual care may have contributed to the negative outcome in this trial, right? So, remember that very aggressive incentive spirometry was also being deleterious in the patient. Very, let's say, high PEEP and high PEEP strategies could also be deleterious in the patient. So, this study, they pointed against this bundle care, right? Okay. Then there was another study which was ICUF multidisciplinary program. In this, it was what was incorporated: incentive spirometry, coughing and deep breathing exercises, oral care, understanding by the family and the patient about how to expand the lung, getting out of the bed at least 3 times daily for mobilization, and head of bed elevation. These strategies were practiced, and this study showed some good result. In before and after design trial, the ICUF program reduced the incidence of postoperative pneumonia and unplanned intubation in the test group. So, when these strategies were employed, the risk of pneumonia decreased in the patient. And follow-up study was also done of ICUF study, and it was found that all these bundle care, patient was taught to practice it earlier. Slowly, with the course of time, the family and the patient stopped using this bundle care, which increased the risk of complication. So, bundle care, what is taught, should be ask the patient to continue with this care at least for a month or 2 months post-surgery, right, for the best result. So there were bit controversial kind of studies, controversial kind of result on different studies on bundle care of preoperative pulmonary for perioperative strategies to prevent pulmonary complications, right? But definitely in high risk patient, it is suggested that as many strategies can be employed to prevent the post-op pulmonary complication should be employed in the patient with a high risk of developing post-op pulmonary complication. Okay, now other thing which would prevent the pulmonary complication was avoidance of full supine positioning. Now full supine positioning can cause trickling and can cause microaspiration. So a semi-recumbent position, right, was advised. Now full supine positioning has been advised. Avoidance has been advised as a means of reducing the risk of aspiration and sleep disordered breathing. A 2019 Cochrane review reported that mean decrease in apnea-hypopnea index with positional therapy, and the practice guideline from American Society of Anesthesiologists recommend post-operative non-supine positioning in patients with known or suspected sleep apnea. A separate study also found to decrease risk of hypoxemia in laparoscopic abdominal surgery in patients with elevation of the head of bed to 30 degree. So elevation of the bed to the 30 degree, avoidance of supine position should be practiced. This decreases the risk of microaspiration, post-op pneumonia, and also improves the breathing profile of the patient. Then prevention of thromboembolism was another post-op strategy, which the bundle care to prevent the venous thromboembolism, the mechanical compression, the drugs should be used in high-risk patient. An enhanced recovery pathway, low opioids, your prehabilitation, your let's say following the NPO guideline judiciously, low fluid, optimal fluid, all this would decrease the risk of post-op pulmonary complication. So enhanced recovery pathway, that is early mobilization, opioid minimization, avoidance of routine nasogastric tube is practiced to reduce the pulmonary complications, right? So enhanced recovery pathway also has minimized the pulmonary complication. So summary of post-op strategies: initiate deep breathing exercises or incentive spirometry in high-risk patient, not in all patient, and non-invasive ventilatory support may also be beneficial in patient with early respiratory compromise. So timely intervention with the non-invasive supports. Provide epidural analgesia in place of parenteral opioids whenever it is appropriate. For patient with asthma and your airway reflux disease, avoid using NSAID for pain control. Avoid using because they can precipitate this condition. Avoid using nasogastric tube after abdominal surgery. Use only when it is needed, and use enhanced recovery pathway and goal-directed fluid therapy in high-risk patient if appropriate, right? So these are all post-op strategies to prevent the pulmonary complications. Okay, now before ending this topic, I want to talk about this ARISCAT risk index, which has independent risk indicators which point towards the post-op pulmonary complication. So in ARISCAT risk index, we can calculate the ARISCAT risk index in patient with a high risk for developing post-op pulmonary complications. So what are the independent risk factors? Age. Age is one of the independent risk factor. Age more than 80, right? The risk score has been given 16, and between 51 to 80, it is 3, and less than 50, 0. Then preoperative oxygen saturation, if it is less than 90%, 17, the risk score has been given, 91 to 95, 24, and more than 96, that is 8. Then your respiratory infection in the last month, okay, sorry, more than 96%, 0. Respiratory infection in the last month, 17 is the risk score. Preoperative anemia, 11 is the risk score. Surgical incision, where it has been given, upper abdomen 15 and intrathoracic 24 is the risk score. Duration of surgery more than 3 hours, it is 23, 2 to 3 hours 16, and less than 2 hours 0. Emergency surgery, the risk score of 8 has been given. So this risk score, these are the independent risk predictors. The risk score is calculated. If the patient has less than 26 point, the risk of post-op pulmonary complication is 1.6%. If it is intermediate, 26 to 44 points, the risk score, the 13.3% risk of developing post-op pulmonary complication, and if more than 40 equal to 45 points, 42.1% is the pulmonary complication seen, and patient comes under a high risk class of developing post-op pulmonary complication. So in patient with the high risk of developing post-op pulmonary complication, all these strategies, if the ARISCAT risk index comes in intermediate or high risk class, put the patient in intermediate or high risk class, we should try to use all the strategies of perioperative strategies to minimize the post-op pulmonary complication, the pre, the intra and the post-op strategies as much as possible. More and more strategies you will employ, less and less would be the chance of developing post-op pulmonary complications in the patient. So this is all I wanted to discuss in strategies to prevent perioperative pulmonary complications. Thank you.